Welcome! September being Polycystic Ovary Syndrome Awareness Month, this webinar brings us to the perfect setting to be speaking on scaling weight management and fertility in PCOS. I'm Sarah Ramaya, Curriculum Design Specialist and Webinar Coordinator at ASRM. Before we begin, please note this webinar was developed by the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. Please note all attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question and answer chat window at any time. We will read as many selected questions as possible to the presenters. However, our panelists have requested and they want an engaging and interactive webinar, so you are encouraged to introduce yourself on the chat window. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. Before I begin, let me introduce our moderator for today's session, Dr. Anuja Dokras. Dr. Dokras is Director of the Penn Polycystic Ovary Syndrome Center and Professor of Obstetrics and Gynecology at the Hospital of the University of Pennsylvania. Dr. Dokras directs a multidisciplinary program for women with PCOS with access to nutritional, dermatological, weight management, and psychological services. I'm going to hand over the webinar to Dr. Dokras to introduce an excellent panel and to engage us on the topic. Over to you, Dr. Dokras.
Thank you so much, Sarah. Welcome everybody to PCOS Month. And I must give a shout out to the PCOS patients out there who really have advocated and identified and got approval for September to be PCOS Month. And that has definitely increased awareness for the syndrome. We have a teal ribbon up there because teal is the PCOS color. And so with that introduction about PCOS Month, let me introduce our amazing panel. We have experts in the field of PCOS and my dear colleagues and friends. So I'm really excited to be part of this and looking forward to this coming hour. So I'll just go around on my screen here. I have Dr. Heather Huddleston. She is from the University of California in San Francisco. Heather runs a multidisciplinary PCOS program very much like we do on the East Coast and has a number of research studies looking at mood disorders, and she's going to talk a little bit about that, so I don't want to give it all away. Next on my screen, I have Dr. Emily Jungheim, who is at Northwestern University, and she is the division director there for reproductive endocrinology and infertility, and has been doing some amazing work with lifestyle modifications. So we look forward to hearing that as well. And then we have Wendy Vitek on the screen here. And Wendy is at the University of Rochester. Wendy is a reproductive endocrinologist, but also boarded in obesity medicine. And she's going to bring some of that expertise. And if I might say that, Wendy, she's also the fellowship program director for the new fellowship program at the University of Rochester. So amazing group here. And what we're going to do is I'm going to start with presenting a case. And we really want this to be interactive. So please start asking questions at any point. We are going to break up the 3 talks and follow each of them with some time for question answers so that it's not all at the very end of this hour. And here is the first case that's being shared with you. A 32-year-old presents to your office for evaluation of infertility. She has been on continuous birth control pills for almost 10 years. Has been tolerating them well, has had routine GYN exams, and really no other problems. She got married 2 years ago, stopped using her birth control pills about 6 months ago. And as her menses did not resume spontaneously, her gynecologist ordered some blood work and ultrasound. And based on that, the patient was diagnosed with PCOS and then referred to you for ovulation induction. On review of the records, you note that the blood pressure is normal, BMI is 42.4, TSH, prolactin are normal, testosterone is 63 nanograms per deciliter, and both ovaries have a volume greater than 10. So you go ahead and confirm the diagnosis of PCOS, and we'd be interested in knowing what you would do as your next step. A, review the use of letrozole as first line for ovulation induction. B, screen for diabetes, dyslipidemia, and depression, and then initiate letrozole. C, discuss the impact of obesity on fertility outcomes, and then initiate the use of letrozole. D, recommend a nutrition consult and have the patient return to your office in about 3 months after she has engaged in lifestyle modification. All right, so I can see some of the responses now. And a number of you have selected that you would screen for diabetes, dyslipidemia, and depression before initiating letrozole. And almost an equal number have said that they would recommend a nutrition consult and have the patient come back after 3 months. Very few chose the directly going to letrozole or just discussing the impact of obesity. All right, I'm going to open it up to our panel to just get their input on just the basics as to how do we get started when we see a patient like this. So Wendy, could you share with us in your practice, when we start any discussion about weight management, we're really not aware how that's going to trigger a response in our patients depending on their past history, what they've done. Some are very receptive and some are not. What are some of the tricks you use in addressing your patient, especially if it's a new patient and you don't have a past history with them?
Yeah, I think patients who present for infertility can sometimes be blindsided when the conversation quickly turns to weight. So one approach is to always start by asking the question, can we talk about your weight today? And if I sense the patient is going to be anxious about that term, your weight, I will sometimes make it even more general and say something along the lines of, can we talk about the relationship between weight and fertility? So that way I'm not saying your weight. But in my training in obesity medicine certification, I learned quite a bit about weight bias and stigma. And I'll just point out that bias is associated with making assumptions about patients' behaviors and activities, particularly when they have excess body weight. And stigma involves shame that the patient experiences because they perceive that the doctor has a negative attitude towards their excess body weight or is making assumptions about their behaviors. In one study of individuals who experienced weight stigma, doctors were second to family members as the most common source of weight stigma, with 69% of patients saying they experienced it from a physician. Much fewer reported feeling stigma from nurses, dietitian, and mental health providers. And some of the consequences of experienced stigma can be increased blood pressure, depression, anxiety, low self-esteem, poor body image, and reduced quality of life. So being aware of your own weight bias is an important first step as a provider. And there are, online testing you can do through Harvard. Implicit.harvard.edu has a quiz you can take to unveil or reveal any weight bias you may already have, because becoming aware of it is the first step. Another thing to think about is, what is the environment in your office like? Thinking about the size of the chairs in your waiting room. Is there a private area to weigh patients? Is there a blood pressure cuff that's appropriately sized for the patient? Are there gowns that are sized appropriately for patients who are undergoing procedures? And then just really watching our language, avoiding terms like heavy, large, fat that are stigmatizing, and using words like weight, excess body weight, or talking in terms of BMI.
Thank you. Those were really useful tips. So, Emily, what are the things you talk to the patient in terms of their risks in pregnancy? We now are aware of a number of OB-related risks as well as postpartum. Could you just share some of that conversation that you have with our audience?
Yeah, I mean, I think what's tough is a lot of the data we have associating obesity with the adverse pregnancy outcomes. It's not clear if it's related specifically to a number, a BMI number, or to the comorbidities that are associated with that BMI. And so when I see a patient who is overweight or obese, I really focus in on what other comorbidities they have and try to center the conversation around those comorbidities and discuss how those may influence pregnancy outcomes. And then from there, talk to patients about how we might modify things to improve the degree of those comorbidities and how we might move forward. And sometimes it's a matter of medication. And I know as we're going to talk about later, it may be weight loss, but really try to make it patient specific, looking at her history, her comorbidities, and any other laboratory work that may help me have that patient-centered discussion for what she may be facing in her individual pregnancy. If somebody asks for generalizations, I'll certainly give those.
Yeah.
But I really try to have a patient-centered discussion about those risks.
That's great, yeah. And then the follow-up question, I guess, Heather, is how does one counsel them about the impact of this weight loss on the pregnancy outcomes? And again, I am sure you're going to be answering, it has to be personalized, exactly as Emily said. But again, drawing a little bit from the data that we have, how do you counsel your patients about the outcomes of any weight management efforts?
I mean, I agree. It was a great setup by Wendy and Emily, because I think it starts with that first conversation and getting a sense of where that patient is on their sort of journey and their openness around it. But certainly patients that are open to it, that's where, I really want to make sure I'm having a very full conversation about the data and the opportunities. I think for patients who are getting ready to get pregnant, for sure, we want to look at those comorbidities. And when there is, say, impaired glucose tolerance, really focus in on those as a way to optimize pregnancy outcomes. But even beyond that, I think, especially data from the OWLS PCOS study, we know that even a small amount of weight loss and work on sort of lifestyle management can improve the chance of conceiving potentially, and we think potentially improve outcomes. And so I usually use just that data in a way to sort of make it less personal in some ways and say, I just want to let you know, there is this study very interestingly showed that when patients engaged in X, Y, and Z, they maybe saw that they had some optimistic or positive outcomes. And so kind of leave it out there as like, here's what some of this data says, and sort of allow the patient to take the lead on whether that's motivating for them. And sometimes it very much is. And they say, well, I definitely want to take that time and do that. Sometimes it's not. But I think allowing the patient to have the same information that we have in front of us to help them make their decision.
Yeah. And I also talked to them a little bit about the maternal and OB complications, because I think patients are not aware that PCOS per se does predispose them to gestational diabetes, preeclampsia, and not just the metabolic complications, but even the psychiatric ones in terms of perinatal and postpartum depression. So just an awareness that this pregnancy could potentially be high risk is an important conversation to be had. So with that introduction, let's go on to our first talk that we have this evening. And Dr. Heather Huddleston is going to talk to us on multidisciplinary and mental health considerations for PCOS.
Great. Thank you so much. I'm just going to see if I can get my slides to advance. I know it took a little bit of time last time. Okay, so I'm also going to start with a case and hopefully get some weigh-in from our participants that are here with us in this webinar, just to kind of get everyone thinking a little bit. I will say a lot of these cases and questions don't necessarily have one right answer. But this is a case with a 34-year-old G0 with PCOS who comes into a multidisciplinary clinic. She says she wants to conceive in the next year, but she does want to lose weight and optimize her health first. For the clinic, she had undergone a comprehensive evaluation with a psychologist, reproductive endocrinologist, dermatologist, and nutritionist. We learned that she has a BMI of 33. She has a normal 2-hour OGTT and hemoglobin A1C. A PHQ-9 score, so this is a depression screening instrument, shows a score of 14, which is consistent with upper end of moderate depression or depression symptoms. And then an EDEQ, which is a screener for eating behaviors, shows increased body dissatisfaction as well as some restrictive and binge behaviors. So let me just see. Oh, sorry. Okay, so here is our question, and I'd like to see if we can do this as a poll. As the next step in management, you recommend exercise, reducing caloric intake with a goal of 5 to 10% weight loss, referral to a mental health professional with subsequent evaluations, or metformin. Okay, so it looks like about 8% recommended exercise, 38% recommended reducing caloric intake, 42 said referral to a mental health professional, and 12% said metformin. So kind of a lot of diversity in our responses, which is sort of what I expected. So let's talk a little bit more about sort of some of the issues that I think come up in this case. All right, so there's a lot of things going on for this patient, although it's, I think, very familiar to me, and I expect for a lot of us in patients that we do see. What we see here is that there is an element of depression, there's obesity or being overweight, and then there's an element of disordered eating. And one of the tricky things about these three things is that they are very interrelated and reinforcing in many ways. And so the question becomes, when we want to address the health of this patient, and there's these three sort of features, what's the best way to approach that? So let's see. I'm going to first talk a little bit and unpack those three features and talk a little bit about how they surface in PCOS and how we can potentially try to get the best possible approach to a patient with them. So this is a study by Dr. Dokras' team. And I think many people probably know, but if you don't, it's, I think, very important to know that we know that depression is very increased in PCOS. This meta-analysis of many studies has shown about a 4-fold increase in moderate to severe depressive symptoms. When we've looked, and a variety of studies have tried to tease out what could be leading to that, there's associations with obesity, with hyperandrogenism, insulin resistance, all as potential predictors of why this increased rate of depression is seen. This is from a study that we did where we looked at patients in the cardia data set. So these were not even patients who had been diagnosed with PCOS per se, but had hyperandrogenism and oligomenorrhea. And across the lifespan, we saw an increased risk of depression, higher depression scores. Here we broke it out by race, and showing that Black women with PCOS actually had the highest rate of depressive symptoms. Now we know that depression can impact how you perceive the things going on for you in your life. And I think that for weight, this is a particularly true. This is a study where we looked at patients in the PCOS study, actually, who had filled out a questionnaire about PCOS quality of life. So looking at this first domain here, or this first chart here, we looked at patients on how much their quality of life was impacted by their body hair, and then we related that to their MFG score, and we saw, not surprisingly, that the worst quality of life was seen by people who had the worst quality of life was seen by people who had the worst MFG score, and vice versa. And when you look at it based on the depression or non-depression, there was no difference. But when we looked at weight, we saw different things. So we actually saw that patients who had the higher weight actually had the worse quality of life. But then if you looked at that was only in the non-depressed. In the depressed patients, that whole relationship was skewed, where it didn't really matter what your BMI was, that you basically had a more impacted quality of life at any BMI if you are depressed. So I think the message being that depression is going to shade and impact how a patient with PCOS really perceives the elements around weight. And therefore, as we think about ways to discuss weight, we need to remember that if there's depression in play as well, there's going to be a very complex interplay there. And then I just want to talk a little bit about eating disorders. So eating disorders, we are now aware, also seem to be increased in PCOS. This was another study where Dr. Dokras' team looked at, a couple of studies have been done looking at eating disordered behavior and showing this increase in patients with PCOS. Particularly things like binge eating disorder. We also have looked at this in our cohort and showing, compared to a control group of patients, that there's this definite increase. If you look here at some of the behaviors, we see extreme diet, excessive exercise, but also overeating being things that are more common in this population. And I think this is very, very important because when this is present, I think it does really complicate how it is that we approach weight. Because if patients are already feeling that they are struggling with, trying to be restrained about their eating, and they're just, again, hearing it from a doctor, oh, you need to lose weight, does that then just drive more disordered eating behaviors? And are we kind of undermining our ability to really help this patient by sort of not really addressing the behaviors behind it? So interestingly, when we looked in this particular study, this was a study where we sent a questionnaire about eating behaviors to patients who we had seen in the past. And we wanted to look and see what were some of the features of this patient population that predicted disordered eating in the future. And we saw, interestingly, the two most important things that really predicted future eating disordered behaviors was their body mass index and depression symptoms. So really getting at that real interplay and the idea that, the very features that are coming across, like body mass index, that make us want to intervene and help them may also be very intertwined with disordered behaviors that are going to take a more complex, nuanced approach. So to sort of summarize this little section, and I wish I had more answers, I'll try to throw out one slide at the end with a little bit of optimistic news. But what I wanted to get across is that mental health, particularly depression and eating disorders, are really closely linked with weight for many with PCOS. I think, and this is true for myself, I think providers in general currently underestimate the role of mental health in optimizing healthy outcomes for women with PCOS, and it's something we need to do a better job at. There's really been insufficient research, I think, at the best approaches of addressing these interrelated conditions. We tend to want to just focus on sort of the objective, what's on the scale, what are the blood tests, and how do we fix that? Multidisciplinary approaches, I think, have at least the first little inkling of a hope at connecting providers across disciplines, which I think is really critical. So having REIs, mental health, nutritionists, being able to sort of be talking to each other about these patients, I think is our best hope for being able to really help this group. And then just to, as I said, leave on a somewhat optimistic note, this was a recent study that came out of Europe, but I thought it was very nice, where they looked at a kind of a cognitive behavioral therapy lifestyle intervention in PCOS. And this was really more about having this patient population meet in groups and talk about behaviors, talk about what it is that drove their eating, et cetera, as well as thinking about weight loss and exercise, but really try to bridge some of those elements we've been talking about, and showed a very successful sort of 7-fold odds of allowing for a weight loss in the patients who did the lifestyle compared to the control group. So I think hopefully we'll see more discussion and more movement in this area of really trying to tease apart and look at what's happening with this group from the behavior and mental health side. And with that, I'm happy to take a few questions before we move on to the other two talks.
Sorry, I was on mute. Thank you so much, Dr. Huddleston. So our format is a little different, and feel free to ask questions right after the talk. And of course, we'll keep some time at the end. Heather, I was so happy that you ended with the cognitive behavioral therapy study, and there are a couple more, that have been published in the PCOS field, which has been good for us as practitioners to know that these options do actually move the needle a bit. But in a more practical sense, how does one apply this? Where are we sending our patients to get some of these treatments, or what are the resources that are available to our patients within this category?
Yeah, I mean, I think I rely a lot on my mental health colleagues to find out where are the best options to send patients. And sometimes it depends a little on the patient. So I know in San Francisco, there is, and I'm sure in many cities, there's eating disorder groups and eating disorder treatment centers. So like for binge eating, I've had a patient who went even to a live-in center to have sort of intensive treatment. So sometimes it's a matter of finding those specific resources. Sometimes there's also just practitioners who individually do cognitive behavioral therapy that the patients can be referred to. So I think in any community, there's a variety. But for me, I know that it's been helpful for me to make connections with specific mental health providers who can be kind of the best resources, because I'm not always in the know as much as they are on best referrals.
Thank you. And I think this was the same question that Emily asked as well in the chat. And a quick follow-up to that. So there's CBT, and then could you touch a little bit on pharmacotherapy for depression? Like, are those medications, do some of them cause weight gain? We really haven't delved into the role of antidepressants in a PCOS population that I've seen in studies or trials. But a lot of our patients who come to us have it on their med list. So can you talk a little bit about pharmacotherapy?
Yeah, I mean, I think I actually find in our PCOS patients that I'm surprised there aren't more on treatment of some kind. I mean, the amount of sort of depressive symptoms that we see is pretty widespread. And I don't actually feel like as many as you might think are being treated. I think it's an under-researched, underexplored area. I think it's probably underutilized, especially when there are sort of disordered eating, anxiety and disordered eating at play. The research in non-PCOS populations would suggest that often medications like an SSRI or Wellbutrin can really be helpful in those patients. And so I'm not sure we're thinking about it enough. I'm not a psychiatrist, but it is an area that I think we need to sort of do more work on in PCOS.
Yeah.
Yeah, I mean, one thing that comes up in the obesity medicine approach is Wellbutrin or bupropion is a medication that can sometimes help with anxiety and depression, but particularly impulse. It's why it's sometimes used to treat like tobacco addiction. There's some data it may be supportive of treating like binge eating disorder, but I don't think it's FDA approved for that indication. It's also, I think, category B for pregnancy.
Thank you. So in the interest of time, we will move on to our next presentation, but I see there are a few questions. They're in the chat, and that's fine. If you guys want to put the questions in the Q&A, we can see both of it, and we might try to answer some of those as we go along as well. But I now invite Dr. Emily Jungheim to talk on lifestyle management in women with PCOS.
Thank you. It's really fun to be here. Let's see if I can figure out how to advance my slides from here. There we go. Okay, so I pose a similar question that we had at the beginning. You have a 34-year-old G0 with PCOS and anovulation who'd like to conceive. Her BMI is 40, normal glucose tolerance test, and she's otherwise healthy. I don't know that this is actually going to come out in a poll. I hope it does, but what would you do? Oh, here we go. Would you require weight loss before treating or recommend weight loss and treat? So here we only have two options. Our results, and so 89% say recommend weight loss and treat, and still a healthy percentage of you guys, 11% said require weight loss. And there's so many different pieces to take into consideration here. She's 34. How long is it going to take her to lose a clinically meaningful amount of weight? There is some data that if your BMI is 40 or higher, you may need to lose even more than 5 to 10% of your body weight to improve ovulation. And then what BMI should she be trying to attain? It's just tough. And I'll tell you, historically, when I used to ask this question like 10 years ago, most people would say they required weight loss. But then, as many of you I'm sure are aware, we got some backlash from from our patients. There's a New York Times article entitled, I think it was What to Do When You're Told You're Too Fat to Get Pregnant. And a lot of us started to recognize, well, it may not be the obesity that's really preventing some of these women from conceiving, and losing weight may not help all of these women ovulate. And as the other panelists have said, you really need to talk to a patient when they're ready to lose weight. They may have tried something before and it didn't work. Another thing that I think can be tough is what resources do patients have available to them? I was in St. Louis for 16 years and just moved to Chicago. And what's nice in Chicago, I'm in a state that has mandates for fertility treatment. And I think that really does give people more flexibility in terms of what they can do, when they can do it, and being able to treat them effectively. But when I was in St. Louis and Missouri, a lot of my patients didn't have insurance coverage for fertility, and certainly didn't have coverage for things like a nutritionist or bariatric surgery or other things, and maybe not even access to some of these things that we recommend, because it's just, as a medical community, there weren't as many options. So that gave me an opportunity to really kind of look into what data was out there on what I could recommend to my patients. One piece of work, body of work, that I find to be really, really helpful and insightful is data from the Nurses' Health Study, where they've looked at dietary patterns and how those associate with ovulation. And this isn't to say that eating this way will help someone ovulate better, but in the studies, again, just looking at dietary patterns, these patterns I'm going to discuss were associated with regular ovulation, as opposed to more of a Western style diet that we typically think of. Another thing I'll mention is that we do know these diets are associated with improved health later in life. So those chronic conditions we think about, like diabetes, cancer, cardiac disease, we know that people who choose to eat this way in randomized controlled trials see improvements. So, these aren't randomized controlled trials that show improvements in ovulation, but the long-term data does show that they're better for people's long-term health. We've got this captive audience and an opportunity to really make an impact. So this is a good time to introduce it. So the way I talk to my patients about it, when we're talking about nutrition, you've basically got two things. You've got macronutrients and micronutrients. And to make it really simple, in terms of the macronutrients, you've got carbohydrates, proteins, and fats. When we think of carbohydrates, there are good carbs, and then there are bad carbs. And I know for a lot of our population, they talk about cutting carbs out and really that being the way to go, but it's not sustainable. So good carbs, we're really talking about whole grains, whole fruits, whole vegetables. We've got to get our protein too, and a lot of times people will focus on eating things like chicken, but I would say that's really a neutral meat. When you look at the Nurses' Health Study, it wasn't associated with better ovulation or worse ovulation. If you're going to eat animals, really what the Nurses' Health Study would suggest is that you should be eating fish that have omega-3 fatty acids. The omega-3 fatty acids, the biological plausibility there is it decreases inflammation, which can be elevated in women with PCOS. And most of your proteins you really should be getting from vegetables and nuts. So again, higher intake of vegetables and nuts, proteins from those versus meat was associated with improved ovulation. Fats, avoid any source of trans fat. And this can be tough because overall that's been eliminated as a measurable source. So if you look at the nutrition label on a food, you'll see zero trans fat in just about everything. But you really have to look at the ingredients because they're only required to report it if there's a certain amount of trans fat in there. I know for myself, I never eat just one serving size. So crackers are a large source of trans fat. And if you're eating 3 servings, you're getting a sizable amount of trans fat. It's just that single serving, it's not going to pop up in there. So you've got to look at the ingredients and make sure that you're not getting trans fat from there. It's not only associated with worse ovulation in the Nurses' Health Study, but also, again, increased risks of those chronic diseases that are seen often in women with PCOS, diabetes, cardiac disease, and cancer. Get your fats from vegetable and nut sources. And again, if you're going to eat animals, eat fish. That omega-3 fatty acid is really the way to go. In regards to micronutrients, folic acid, not only are we avoiding or preventing or decreasing our risk of neural tube defects with that, but in the Nurses' Health Study, people who had more regular intake of folic acid had improved ovulation versus people who didn't. And so if it's a prenatal vitamin, it's going to have at least 800 micrograms in it. And so that's generally what I'd recommend to folks to do. And again, teaching folks to look at the nutrition labels, it's important. Really focusing in on trying to distinguish between something that's a refined carbohydrate or a good carb versus a bad carb, looking at the fiber content versus the sugar content. Again, preferably you're buying foods that don't have nutrition labels because they're from the periphery of the grocery store, whole foods, vegetables, fruits, whole grains. But that's the way to go. And again, talking to your patients about looking at that nutrition label and the ingredients in that food. Another thing that I find to be helpful in trying to distinguish between a good carb and a bad carb is talking to patients about glycemic index. And so glycemic index is a measure of if you eat a carb, how much does it make your blood glucose go up? I'll talk to patients about doing a Google image search for glycemic index. And you'll see graphs like this where you've got green, yellow, and red, and you really want to focus on stocking your pantry with those things that are in the green zone. If there's something that you like in that zone, replacing some of those red zone foods with those green zone foods. So avoiding those things in the red zone. You can have a bullet once in a while that makes it more sustainable, but really where you should be stocking your pantry is with those things in the green zone. And so the classic example is instead of making white potatoes, using sweet potatoes instead. Another thing that may seem simple, the Earth study, which is another study out of Harvard, where they looked at IVF data. They found an increased chance of live birth in people who focused on whose produce was organic versus produce or had low pesticide residue versus high pesticide residue. And so what are some foods that have high pesticide residue, these dirty 12 that people talk about that are listed here? Basically anything where you're going to eat the peel is going to tend to hold on to the pesticide, whereas clean foods are those where you're peeling something off of it. And so another way to avoid pesticide residue is to buy organic. And if it's not organic, rinsing it and really cleaning it to get those pesticides off. Again, we haven't seen it in randomized controlled trials, but it's a place to try to see if we can make a difference. And that Earth study shows some evidence that it may be helpful. And then finally, in regards to exercise, this slide is taken from Lauren Wise's Presto study, looking at different types of exercise and time to pregnancy. If you look at vigorous physical activity, it can actually be associated with decreased fecundability in normal weight women, but in overweight and obese women, you get increased fecundability with any type of exercise, whether it be moderate or vigorous. And so encouraging exercise among women can be really, really helpful. Again, the biologic plausibility here, decreased inflammation, increased insulin sensitivity, and perhaps improved ovulation. And overall, a lot of patients, when I talk to my patients, they don't really know how to start exercising. think a lot of the simple tools that we have out there, like Fitbits now, and your phone, just looking at the health app, opening it up and getting a pedometer and talking about trying to get 10,000 steps a day can be a really great place to start. And then finally, one thing that I think a lot of our patients skimp on, and I think we all do it too, even our super healthy, normal weight patients, is sleep. And there's a lot more information coming out about sleep. Certainly in our PCOS patients, we need to be cognizant of things like sleep apnea and make referrals to sleep medicine docs as appropriate. But a simple place to start in terms of behavior is just talking to patients about what do their sleep patterns look like? Do they have a regular bedtime, or do they jump around from place to place? So this is a study that we started in St. Louis with a grant from the March of Dimes. We enrolled 179 pregnancy planners, aged 18 to 40 with regular periods in this case. And what we did was we used a motion watch that they wore all the time. And from that, created an algorithm where we were able to detect when they went to sleep, when they woke up, and the quality of their sleep. And then we looked at their time to pregnancy. And what we found was that overall, women who had a more irregular sleep time, so if you looked at their bedtime from one day to the next, it was more variable and less scheduled and less predictable, they had a longer time to pregnancy. Comparing the most regular folks, which was about an hour from one night to the next, versus people who had the most irregular patterns, so over 2 hours from one night to the next. The women who had the regular sleep patterns got pregnant 4 times faster than the other women. Again, this wasn't a randomized trial. Who knows what else was associated with those irregular sleep patterns, but it's a place to start. And maybe have some patients at least start to circle back and look at what they're doing on a day-to-day basis, and trying to get a more regular schedule that may be helpful in other regards to their life as well. Okay.
Thank you so much, Emily. You brought up so many interesting points there, and we have a few questions in here as well. So the one thing I wanted to mention was the vigorous exercise, because I too have noticed in this past year, I have had so many patients come and say to me that, oh, I read on the internet that doing vigorous exercise is not good for me. And they ask for advice as to, what is the type of exercise I should engage in. So I'm glad you addressed that. And in the interest of time, we'll do some of the questions at the very end. But the one question, following up on your very first introduction and the New York Times article, we have a question in the chat for what is the cutoff in our practices in terms of offering fertility care. And I know we've talked about cutoffs for IVF and sometimes related to the surgery centers, but could you comment on cutoffs just for anybody who walks in for fertility care, be it just ovulation induction, really not related to going to an operating room facility?
For my practice, generally, again, I'm focusing in on comorbidities. And so if somebody has a BMI of less than 45, generally I'm comfortable moving forward with treatment. If it's over 45 and they have some comorbidities that we need to get a handle on, I'll talk about trying to get below that BMI of 45. Again, it's tough because I don't know that getting below that number is necessarily going to change anything. But there is some data from our anesthesia colleagues as to where these cutoffs can be helpful if we need to go to the operating room. But really where I'd require weight loss would be a BMI of 50 or higher. Again, age can always play in there and be so difficult. And a lot of those cutoffs, as you mentioned, are set up by our surgery centers and not by us necessarily. And I think another place where we get into trouble is if we have a patient who needs urgent fertility preservation. And if we're working within a center that has a surgery center and the BMI is 45, we actually have some great techniques that we've used to take someone to the main OR and try to, you can bank. Again, if it's urgent, you can bank, but if you've got somebody who is 40 and has a BMI that's greater than 45, and they say, yeah, I really do want to try to lose weight, but I'd like to preserve some of my embryos, that may be an opportunity moving forward too. I think we have yet to see people push the limits and try those things, but I think they're probably coming.
Thank you so much. I think, again, in the interest of time, let's move on to the next talk by Dr. Wendy Vitek. And we will try to get to all the questions at the very end. We might have about 5 or 10 minutes over if everybody wants to stay on, or we could even start responding to some of these questions. I think, Emily, somebody wanted a reference to the study that you were sharing with ovulation and diet. So we can start doing that in parallel as well. So Wendy's going to talk to us about anti-obesity medications.
Okay. So just wanted to share a story about a patient I'm currently treating. She's 30. She's had one successful pregnancy, but now she's experiencing secondary infertility. She was diagnosed with PCOS postpartum in the year that followed her pregnancy. So this was a new diagnosis. Though she's been dealing with obesity, she said, since age 7. She's dieted since age 8. Her recollection is from her irregular periods as a teen. She was placed on birth control pills. Her weight progressed into the low 300s. Her height was 5 feet 9 inches. Her BMI was in the low 50s at that point. She stopped birth control pills around age 27 and quickly became pregnant. She gained about 40 pounds in pregnancy, and that is a little more than the recommended guidelines, but not unusual for women with PCOS. We do tend to see that they gain potentially a little more in pregnancy, particularly if they're normal weight or just overweight. Postpartum, we tend to see that PCOS patients lose a little bit more, but maybe end back up at a year where they started. In her case, she breastfed for 2 to 3 months and lost some weight, but at 6 months she natered. And then she started to increase, and this is a chronic dieter, so she went right back on to the things she's tried, like Weight Watchers, intermittent fasting, keto diet. She has an Apple Watch, 10,000 steps a day, 30 active minutes per day. She was also placed on metformin around the time of her PCOS diagnosis. She presented to me in January 2019. Her screening for comorbidities was surprisingly negative. The only obesity related consequence she was experiencing was knee pain. We discussed the pros and cons of approaches like starting anti-obesity medicines at that time or pursuing bariatric surgery. She worked as an ICU nurse and has seen complications from bariatric surgery and felt that was a direction she did not want to entertain at this point in time. She was anovulatory, so we did agree to try some rounds of letrozole. She was counseled that she may not ovulate, and that turned out to be the case. I did a stair-step protocol with 2.5 letrozole, no response, 5, 7.5, no response. After about 45 days in the stair-step, we called it quits. We ordered some gonal F. She came back in for a repeat baseline, no change in her status. So she tried letrozole 7.5 with 75 overlapping gonal F the last night of letrozole. And after about 5 to 7 days on gonal F, she did get a dominant follicle and she ovulated. She did not conceive. This was right around the time the pandemic hit, and we agreed to pause her fertility treatment given that she was at high risk for COVID, given her line of work as an ICU nurse and also her obesity. So during that time, she reported that her migraines were worse, her anxiety was worse. So she had previously been on topramate and bupropion. So she re-engaged those therapies through her PCP, and she did note that that helped her maintain and even lose 4 pounds. Topramate is teratogenic. It can cause cleft palates. So, we talked about contraception, and she wanted to be on cyclic progestin, like Provera. And if she had a positive pregnancy test, she was going to stop the topiramate immediately. So, when I was talking to her about her options, and when she recently re-engaged me, we're revisiting these. What are the options that are FDA approved for obesity? These are medications that are available when individuals have a BMI greater than 30 or a BMI greater than 27 with at least one comorbidity. These are the ones that are FDA approved. In the interest of time, I'll just summarize that I have them in order of placebo-subtracted weight loss. So these, to be approved, you typically have to demonstrate that it results in about 5% body weight loss. There has to be a placebo arm, and typically weight loss in the placebo arm is 2 kilograms. So like orlistat gets up to about 5 kilograms, and you can see the most impactful one is semaglutide, which was recently reported for obesity in June 21 in New England Journal of Medicine. And that has an absolute weight loss of about 15 kilograms. So you'll note that all these medications are contraindicated in pregnancy, which really ties our hands as reproductive endocrinologists. So in the case of my patient, we talked about like pausing fertility treatment so she could be on topiramate. And we did talk about liraglutide at that time. That is a GLP-1 agonist. It delays gastric emptying, and it also potentiates the action of insulin. It has been studied in women with PCOS, whereas these other medications have not been specifically studied in women with PCOS, other than orlistat, which has been tried in some of the RMN trials related to weight loss. And I believe your ALP PCOS study had orlistat, Anuja. Yeah. What we see in the controlled trials with liraglutide in women who have PCOS is that their weight loss seems similar to other populations. It's right around 5 kilograms. And I see one of the investigators of these studies, Dr. Elkin Hirsch, is on the call. So thanks for joining us. This is the one I'm most interested in. It is a GLP-1 agonist that is a weekly injections, whereas liraglutide is a daily sub-Q. I find that our infertility patients are very willing to do a daily sub-Q injection, so it hasn't been a deal breaker for an infertility population. But semaglutide has the advantage of being a weekly for obesity, and it's similar to liraglutide, but it binds to albumin, and that's how it has an extended release. And that may be why it has such a big impact compared to other GLP-1 agonists. So there's really only one trial that's very small in women with PCOS that actually looked at fertility as an outcome. But there have been about 8 studies in women with PCOS, and what they've shown is consistent weight loss with GLP-1 agonists. They've shown that most decrease testosterone. There's been a variable or mixed data on measures of insulin resistance, such as HOMA-IR and whatnot in these studies. And menstrual patterns have not consistently improved, which is interesting because we typically assume that 5 to 10% loss of body weight should allow like roughly 80% of women to start ovulating. But nonetheless, in this trial, this group of investigators compared liraglutide with metformin, 1,000 milligrams to metformin alone. And they randomized 14 women with PCOS to each group. They treated them for 12 weeks. Most liraglutide studies are around 26 weeks up to a year. They did a 2-month sort of washout because, again, liraglutide's not approved in pregnancy, though there is some data from women who take it for type 2 diabetes that it hasn't been clearly associated with teratogenicity. There were women in both arms who became pregnant. They ultimately had 12 in the combi group that went on to IVF, 6 of which became pregnant. And then they followed them even further. The non-pregnant patients, 2 out of 6 became pregnant at a year. In the IVF patients who were pretreated with metformin, 2 became pregnant from IVF, and then there were 2 additional pregnancies. So in this very small trial, they saw that combination treatment was superior to metformin, and that was both in IVF and 12-month outcomes. So I'll just say you don't have to be an obesity medicine specialist or board certified to prescribe these medications. The only one that can be challenging to prescribe is phentermine because it's controlled. And certain states have laws around who can prescribe phentermine, but most of the other medications, you just have to get facile at the pre-authorization step. But that's something fertility clinics are pretty good at doing.
Thank you so much, Wendy. That was really useful.
Mhm.
And, something that we all struggle with is this, we are comfortable prescribing metformin.
Mhm.
But as you look at that list that you have up there, and how many REIs will eventually be comfortable prescribing these medications, time will tell, because I don't know if, 20 years ago, we were not comfortable prescribing metformin either. So
Yeah.
over time. And so the question, I have is a follow-up to a comment which is in the chat saying that the problem with semaglutide is it has higher teratogenicity compared to liraglutide. And can you comment on that? Because as I look at the literature, most of this comes from a mouse model and not in humans. And I struggle a lot because if you take a patient off these medications, and we know the success rate per cycle and per attempt is low, if it's going to take her another 6 months, she's probably going to gain a lot of the weight she's lost. And what would be ideal is if we could keep them on some of these medications, still the positive pregnancy tests like you were talking about your patient that you presented. So what is the data in terms of teratogenic effects, and what is your practice? When do you stop some of the weight loss meds?
I mean, I think we're uniquely positioned in fertility care because we know the second a patient has a positive pregnancy test, the literature I've seen in the liraglutide exposed pregnancies in women with type 2 diabetes, these women weren't really acknowledging or being diagnosed with pregnancy until 8 to 12 weeks. So, I mean, much longer exposures, like through mid-first to complete first trimester exposures, and really not seeing birth defects. So I've been comfortable prescribing liraglutide and then stopping it with a positive pregnancy test. I don't necessarily do ovulation induction though while they're being treated with liraglutide. My comfort level would be, diet, exercise, sleep, stress, depression, eating disordered management, then add on liraglutide, potentially to metformin in women with PCOS. I think there's reasonable safety to add the two. And then if they fail to spontaneously conceive, stop the liraglutide for like a month or two and then bring them into a letrozole cycle. Semaglutide's so new, I haven't had a chance to prescribe it yet. I'm hoping my patient will consider this option while she's not engaging in active ovulation induction. The cost per month is about $1,300. Patients in the trial were on it for a year. I'm not expecting her, if she opts for this, to be on it for a year. And I'm also not sure if her insurance will cover it. Liraglutide's a little less expensive. It's about $1,000 a month. And I have found most insurances will cover it if you do proper documentation in the pre-auth.
And another follow-up question, I think somebody presented a case very similar to yours asking what the next step would be. So I
with
think
the very high BMIs.
Correct.
Yes.
And so we answered that. And we didn't touch upon bariatric surgery here, but there was a question about, the impact of rapid weight loss, and how should we counsel our patients during a period of rapid weight loss. Again, most of what we have talked about, unfortunately, does not result in a rapid weight loss, and we wish it would. But can you comment a little bit on the negatives of rapid weight loss and fertility?
Yeah, I think there's some concern that with rapid weight loss, particularly surgical induced, but also like with extreme caloric restriction, less than 1,500 kilocalories a day, that it may increase the risk of miscarriage. And I think in the New England Journal studies, when they looked at post-bariatric patients who became pregnant, it wasn't clearly beneficial in that the neonatal death rate was higher in women who had become pregnant after bariatric surgery, though it didn't reach statistical significance. Certain outcomes like LGA were less common, though SGA was more common. And some of the maternal outcomes looked beneficial, but it seems like neonatal, it's not a slam dunk that bariatric surgery improves outcomes for the offspring.
And so currently the recommendation is okay to be pregnant after a year, 18 months, or after weight loss has plateaued? Which one of the three?
Yeah, I think it depends on the procedure. If it's a sleeve, less malabsorption, I would think, and you plateau sooner, so you'd probably be more like a year, but in some of the more involved surgical approaches like a Roux-en-Y, and then there's a duodenum switch that's sometimes done, very malabsorptive. I think you'd be more like 18 months, a year to 18 months in those populations.
Great, thank you. And Heather, there was a question about childhood trauma and whether this has been studied in PCOS.
You know, I have not seen that studied specifically, but it may be out there. You know, I certainly think that if someone has had childhood trauma against the sort of backdrop of PCOS, I think that's, you know, there's probably sort of a double hit potential situation there where there's already some maybe biologic tendency toward depression, and then with an environmental effect, you know, I think those could certainly work together to create a worsened situation, but I'm not aware of any studies on that. Are you, Dr. Dokras?
Yeah, I was trying to recall, I think so there is an Australian longitudinal cohort, a population-based group that's being followed. And they have conducted a number of surveys in this population. And if I recall correctly, there is a validated questionnaire for childhood trauma that they did use and did not find any differences, but that's the only one, if at all, that comes to mind. Wendy or Emily, do either of you know any other data?
Mm-mm. Nope.
It's an opportunity for research.
Yes, yes. So I think we have answered most of the questions that I can see here on the chat. I want to thank everybody for their participation. And really the one thing I have come away with as I listened to all these talks was what we need really is a multidisciplinary approach to this. You know, weight loss is challenging. Weight loss in women with PCOS is challenging, and weight loss in somebody with PCOS and trying to achieve a pregnancy. You know, we are just adding another layer of complexity. And from the very first talk, Heather talked about, you know, either be it a psychologist, a therapist, or a group for the cognitive behavioral therapy. And we touched upon a little bit in terms of antidepressants, and would it be an internist or a psychiatrist who's helping manage some of the underlying mood disorders. And Emily talked about, again, an in depth about diet and nutrition. And I'm not sure how many of us have time to engage in that kind of conversation with our patients, leave alone after diet, nutrition, talk about sleep habits, right? So again, thinking about who are our colleagues whom we need in this multidisciplinary approach, and the model of care to be able to adequately counsel our patients about the different aspects. And so what comes to mind is for sure the nutritionist or a registered dietitian. But even a little beyond that is the food for thought, I think, from Emily's talk. And then finally, Wendy has the expertise with all these medications. And I certainly use a colleague at Penn whom I refer all the patients to. I don't prescribe it myself, but I see this as an opportunity to really revisit our models of care and identifying other partners in our community so that we can offer top-notch care to our patients. So thank you again for bringing all of this to our attention and for your expertise. I will hand it over to Sarah.
Thank you to the fantastic panel and Dr. Dokras for moderating such an engaging case-based interactive discussion. Thank you to Dr. Hoeger, Chair of the Androgen Excess Special Interest Group at ASRM, for spearheading and bringing together an expert panel. And to the attendees, thank you for joining us and engaging in the conversation. You will receive a survey right after this session and by email. Your feedback helps us give you the most relevant content. Your input is appreciated. This session was recorded and will be available on the ASRM website in the near future. Please watch your email for notification about future webinars. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar. Thank you. Thank you, everyone, for joining such a fantastic session. Thank you to the panel, to Dr. Dokras for moderating such an engaging case-based interactive discussion. To our attendees, thank you for joining us and engaging in the conversation as well. So you will receive a survey right after this session and by email. Your feedback helps us give you the most relevant content and your input is appreciated. The session was recorded and will be available on our website in the near future. Please watch your email for notification for future webinars. And for any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar. Thank you.
Thank you. Bye-bye.